Good morning, Lorraine. Thank you for the interview. My name is Hassan Shenassa. I am currently a gynecological surgeon at the Ottawa Hospital and University of Ottawa. I am an OBGYN, but I have not been practicing obstetrics for the last 10 years or so, concentrating mostly on surgery and surgical education.
Where were you in your career? When did you first consider giving time to working in underserviced settings globally?
That's interesting. You know, my dad is a physician. He trained in Mayo Clinic in Rochester, Minnesota, and that's where I was born. When I was about 2, we moved to Iran, where my background is, where I'm from. And he went to a northern city in Iran and started working there and really changing the environment. People were dying from meningitis and not recognizing what it is. And he changed all that. And I remember as a child wanting to be a physician. And the big thing with that was that I wanted to do developing world medicine. So the interest really started then. And then after my residency, you know, things got in the way. We started having kids, and then you think, oh, I shouldn't leave the kids. It might be too dangerous and this and that. And you get comfortable in your own ways. And it was in mid-career when I was about late 30s that I started looking at doing global health work.
I hope that wasn't your mid-career in your late 30s.
Early on in the career.
Where was your first global experience?
You know, my wife is an anesthesiologist and she's from Trinidad and Tobago. And we used to go on holiday there. And after about a week or so sitting on the beach, I'd get bored. So I met up with one of the local OBGYNs who's friends of the family. And he was very interested in learning more laparoscopic surgery. So I ended up donating a lot of equipment there from the Ottawa Hospital, and then doing work with him, doing a lot of teaching. So that was really the first experience that I had teaching, and with very little education as far as my understanding what the needs are back then. After that, I started doing some work in Africa, in Tanzania, with another NGO. And again, doing surgeries, thinking that's what we were supposed to do. And that's when I met up with a couple of the surgeons from CNIS, in fact, on the field, where they had asked me to give them a hand with some of the teaching that they were doing.
How would you say that these experiences that you had first in Trinidad and Tobago and then next in Tanzania, how did they change your understanding of the needs and potentials of underserviced settings?
You know, the thing is that it really feels good to do things with your hands, to do surgery. You accomplish something and you feel great, and you feel like you know, spend thousands of dollars getting on a plane and getting to East Africa and then doing 10, 20, 100 cases, and that you've done such a great job. What ended up happening is that understanding changed for me, that I'm actually not doing good and I might be doing harm. I noticed that the docs would not stay during surgeries because they were so overwhelmed that they would say, well, you guys are here, we'll go and run clinics. So there was no handover of teaching techniques either from them to us or us to them during the surgeries. And then what happened also is that the patients were waiting for us to come. So when they knew the foreigners were coming, they wouldn't actually go see their own docs. So we ended up creating dependencies, and I think we might have even decrease the quality of the healthcare there, because we do big surgeries and it would leave with, you know, very little instruction on how to care for these patients post-operatively. So with when I did end up meeting up with CNIS staff and understanding what they do as far as running courses for the teachers alongside the teachers on how to teach the information that they already know. And then together as a team working on things that are not that sexy necessarily, because you're using models initially and doing dry runs on low fidelity simulation, but really teaching surgical skill and then observing the local doctors doing the surgeries and using those skills. Ended up being that I really understand that is the way to go. That is how we can make a difference in the world, along with the local healthcare providers with a true partnership.
What has been your involvement with CNIS since that time?
I have pretty much exclusively worked with CNIS for global health aspect of my career. So I have been to Africa. I don't actually know how many times, but over the last 15 years or so, sometimes it'd be twice a year, on the average once a year, and places in Ethiopia and mostly Tanzania. And Lorraine, you and I had gone together and got amazing experiences being there with you. And really, the benefit I see is really those local relationships that we've built, and understanding that there's so many healthcare providers that are in need of training, that are so excited to be there and so involved in learning and also teaching. I really do feel that we learn a fair amount when we go. And when I teach my residents, I tell them that you will get more out of this than you will give. And I really do believe that.
In what way do you see that the CNIS work has supported the national health system of the countries that you've worked in?
What I feel is the most benefit from the work we do at CNIS is the partnership we have with the local healthcare providers, and having them really explain to us what their needs are, and then partner with us and teach the local healthcare providers that will then go into the periphery, into the villages and healthcare facilities and do the work. The other thing that's amazing is with social media these days, even on Instagram or Facebook or just texting or WhatsApp, I've managed to keep in touch with many of the healthcare providers, and they'd contact me saying, "Hey, this is what I did. What do you think?" Or we go back and forth. Or, "When are you coming back?" And I found that's been really, really helpful. So the big thing for me is understanding that this sort of pyramid system of almost like an upside down pyramid where you're one or two people from here go to a village in Tanzania and meet up and make partnerships with 3 or 4 other instructors, and together as a group of 4 or 5 end up teaching a group of 20 people over 2 weeks and observing them doing surgeries, and I credit them with some of the tasks that they've been trying to achieve competency in. And then they go and take care of the patients. And you do this multiple times. And eventually, the hope is that we write ourselves out of a job, if you want to call it that, in the sense that many of these centers now don't have us come there. They just run their own courses. And the benefit of using the low fidelity simulation is that the equipment's made, some of the equipment we take from here, but a lot of it is made locally. So we also advance the market there, where they can make some of these boxes for, say, cesarean section, and we're able to work with the local government as well. We usually do meet up with them so that we have buy-in from there. I think that's the best thing I can think of, the spreading of the knowledge, both from them to us and us to them, and then having that keep going forward and eventually without us even being there.
You've already partly answered this question, but in your opinion, how important are the relationships for this kind of global work, the relationships with the colleagues on the other side of the world?
Right. So that's a really interesting question, because with the pandemic going on now, a lot of travel has been stopped, and we have to rethink of how we do things. Uh, the one-to-one meeting somebody and looking in their eyes and watching them smile, having a supper in a local restaurant together, having a cup of tea during break, talking about our social life, our families, how many children do we have, and what the needs are, the local setting, and what Canada is like. All those things are so important that I do worry, and I'm hoping that with the new technology we can get some of that back. But it really is important. You know, we've managed to bring a few of our partners up to Canada to work with us and in our hospitals, and be able to see how we do things. And I remember one doctor who's now chief of the department had mentioned that the biggest thing he learned wasn't necessarily how to do laparoscopy and that sort of thing. It was the respect that we have for women, and how we speak to the women that we see in our practice. And he had taken that back, and he had said that had changed the way he practiced. And that was, if it was only that, it was worth him having come here for a month and partner with me in my office in the operating room, and then just see how we manage healthcare and some of the differences that we have.
That could have a lasting impact.
Mm-hmm. I hope so.
This comes sometimes at a personal cost, this global work. Pardon me. What sacrifices have you had to make? Sacrifices in your career, economic sacrifices, or family sacrifices in order to be involved in this global work?
From a work point of view, we all choose a career path. So mine has always been education. And I was running a simulation program in Ottawa for a while. I was head of the gynecology program for a while. So that has just continued on, and I had concentrated my education to global health. What that does mean is you're often away. So two things. One is from a work point of view, especially if you have a private office, you're paying rent, you're paying your secretary, and you're not making any money, and you're spending money. So definitely from a monetary point of view, there is a hit. Having said that, I don't think of it that way. I just think of it as part of my life. This is what I want to do. If you go on vacation, it costs money. And this is almost like a vacation for me. I get to meet new people. I get to do what I love. And makes it so that the burden of it is not really there for me. What does make a difference is being away from my family. So especially when I had smaller kids, being away for 2-3 weeks at a time was difficult. But to be honest, now with the internet being so widespread, that you're almost there. You know, you talk to your son, and he's in bed and he's chatting. He tells you about his school, and he says, "Oh, Daddy, let me show you something." And he walks over to the basement, showing me something else. It really is almost as good as being there. I remember the first time I went, I actually had taken a satellite phone with me to, you know, these big clunky things that you have with big antenna and stuff, to be able to make sure I can talk to my family. Now, any village you go, anywhere, pretty much there is adequate internet and access to video conferencing, for example. So that has been easier. And I'm hoping sometime in the future I'd be able to take my family with me on some of these trips. Mm-hmm. And then I wouldn't even have to worry about that part of it.
Now, I'm asking this question because I'm hoping that it will help someone who's trying to decide whether they would like to be involved in this work. How were you able to be away from your professional responsibilities, your call and that sort of thing?
We have a really good group at the Ottawa Hospital where if I decide to be away, I can be away as much as I want. A couple of things. Somebody would take my operative time because that's a very rare resource, so they would love to take that, and I can often switch it. And when I was doing obstetrics, again, call, we were all private, so call would pay. So somebody else, if they have enough notice, would be able to take that call. And I've got great partners in the office who were able to always see my patients if emergencies come up. So professionally, it hasn't been difficult at all, aside from obviously not making money when I'm away.
Could I ask you to describe how you have been affected personally by your global involvement?
It's those individual stories. I remember once when we were actually doing surgeries. It was evening time, and we usually work 12, 14-hour days. And one of the healthcare providers came up to my resident, and he wouldn't even talk to me because I was the big professor type of thing. And so they mentioned that there's a lady that's bleeding profusely, and they expected her to die. But he knew that we had worked hard all day, and we were not expected to go try to save her. But if we were going to consider it, they would be grateful. And then my resident came and talked to me. Of course, we rushed over and took care of the situation. But it occurred to me that it's so sad that we have such amazing differences in healthcare in our world. And we don't need that. We don't need to be so different, in a sense that if you're born in Central Africa, your life expectancy is much lower. And if you're a woman, you're much, much more likely to die in childbirth. And that doesn't make sense to me. So that's part of the reason I do what I do. One of the other things that was nice to hear is I had been teaching the B Lynch suture, which is a suture that we use for postpartum hemorrhage on the uterus as a sort of last ditch to try to save the uterus and the woman who's just had a baby. And I taught this with the local doctor who is the chief of that hospital. And she wrote to me on WhatsApp and sent me a picture of one she had done about a week or so after. And she wrote that I saved this woman's uterus and her life because of this technique that we've been doing together that he taught us. And that sort of thing makes such a huge difference in why you do things you do, because it puts that human factor into it.
What advice would you give to someone who is interested in becoming involved in global work? What should they focus on?
I think what you do want to do is have a skill, number one. Number two, get a fair amount of training locally. So we run courses locally in Canada, for example, if you wanted to do something with CNIS. The last thing what you want to do is get on a plane and go somewhere and try to do some work in a hospital or some charity work thinking that you're going to do good. What I tell people who are interested is understand that you're more likely to do harm than good. Right. So in the 1970s and 80s, there was all this Africa aid, that sort of thing. And there was some good from that. And there was a fair amount of dependency that arose from that. If you give free things to someone, they're like, okay, I don't need to do anything. So it's quite complicated what we do, and making sure that you're actually doing good. And some of the stuff that you may want to do that has the most impact is the stuff that's not all that interesting. So potentially going out there and keep doing cesarean sections on women who are stuck in labor probably is not good if you're going to do it for 2 weeks and come back, right? So it may make more sense, and it does make more sense to make sure that we teach proper techniques if that's what the need is, as opposed to getting in a plane and flying out somewhere and working for 2 weeks and coming back. So it's quite complicated, and I think there are people who've done work that has been shown to improve quality of care. And I think you want to contact those people, hopefully in your departments. Most universities have a global health organization. So getting involved with local organizations, I think, is the first step. Having scale, and then understanding that you may do more harm than good. So try to not do that, and be humble. Understand that you will likely get more out of this than you're giving to the places that you're going to.
All of these organizations, including the CNIS, are struggling with funding and also with the pandemic. Do you have any ideas about how the CNIS in particular can continue its work as it faces these problems?
That has been a challenge. So funding is always a challenge. The government's funding is not always there for us. One of the things we can do is team up with the bigger organizations that are somehow getting a fair amount of funding, but don't necessarily have the skill set to do what they want to do. And that has been what we've been doing with CNIS over the last few years. I think that's a way of looking at things. The other thing I really want, and I don't know how to get around that, is that many of the countries we go to actually do have resources. What happens is that because we come there with our own resources, they're like, well, we'll let these guys do what they want to do. And I like to see more involvements from the local governments as well, to say, you guys do this much, we will do what we can to make this happen, because the healthcare of our local population is important to us.
In concluding, I'm going to ask you, do you have any further comments that you want to make about the CNIS or about your involvement with the CNIS?
I'm currently the vice chair of the organization, and enjoying that role very much. The CNIS is struggling for funding. So if people find that the organization is something that lines up with their core values of partnership and teaching and caring for healthcare of individuals around the world, and especially for women and children, because they tend to suffer most during wars or famines or any natural disaster. And I think if people say, hey, this is something I believe in, and they want to donate to that cause, that would be very, very helpful.
Good. Well, I'd like to thank you very much for your time and cooperation and your insights. This has been Dr. Lorraine Woolford interviewing Dr. Hassan Shenassa.